Nothing here is financial advice. Please speak to your trusted professional advisors. Views expressed by podcast participants are solely their own.
Hello, everyone, and welcome to another episode of Passive Income Doctor. Today, we have a very special guest, Dev Raga, doctor based in Melbourne and podcaster of the Dev Raga Personal Finance podcast show. Welcome to the show.
Thank you very much, Dan. Thank you for having me. And I think it's been about 12 months since we last chatted about your career. So congratulations on your podcast and YouTube channel.
Yeah, thank you. And it's very inspiring. Obviously, you're one of the original kind of podcasters in Australia, and very awestruck to have podcast royalty on the show.
I appreciate the time. Thank you.
So, tell us about your kind of day to day. What your average day looks like, if there's such thing as an average day.
Yeah, so I basically my fellowship is in general practice. I don't do any private general practice anymore. I used to many years ago. I did enjoy some aspects of it. The aspects that I didn't enjoy were predominantly the billing aspects and the financial aspects of it. I found it a drag. Subsequent to that, I did a bit of subspecialty training within general practice, particularly in aged care, in palliative medicine, and also more recently, fully fledged working in the emergency and urgent care space, and also did a bit of training in executives. So did a bit of RACMA training as well. So my day-to-day life at the moment is very flexible. A lot of the time I work from home, which is fantastic. And I do a bit of clinical work, in the urgent care space, which I really love. But certainly that's not how it all started. How it all started was essentially in the traditional general practice space, seeing patients in a fee-for-service environment. And very quickly, Dan, I realized that that wasn't for me. And I wanted to branch out and diversify my income sources. That's where we are at the moment. So, yeah. So my life at the moment is actually pretty cruisy.
Yeah. So let's go back in time. What was money backstory in terms of, growing up? What was the mindset and discussions around money like around the dinner table?
Yeah. So, first generation immigrant. So not much money around, and it's not something that we would routinely discuss around the dinner table. Most people that come here as first generation immigrants, dare I say, are what I call hungry. And me and my family were no different. We migrated from India. Parents were both professionals. Pretty easy to get a job when they landed in Australia back in the 1990s, and I was a child. But we didn't come from wealth. We didn't have much money growing up. And I think that sort of set the fire in me in terms of learning about money. And what started off very naively, actually, I'll tell you this story about, and I've said this to other people, where I grew up in Adelaide. We went shopping to David Jones, which is, for those of the new generation, it's one of those upmarket shops. We would never buy anything there, just couldn't afford anything, but it's nice to go window shopping. And I remember I used to love technology and hanging around television sets and all that. And back then the plasma TV had just been released and it was, retailed at about $40,000. And I thought to myself, there is absolutely no way anyone's going to buy a TV that's costing $40,000. Now, this is back in the 1990s.
Wow.
40 grand back then is probably worth about 120 or 160,000 now. And I thought, there's no way anyone in their rightful mind would actually buy something like that. And I kid you not, right at that moment, a lady walked up to the register and said, "I'll take one of those, please." And that really set a fire in me, saying, wow, there are people out there who can afford a 40 grand TV, which to me was a real lot of money back then. The average salary back then was around sort of $30,000 to $40,000 for most people. And that set the fire. And what started off as a very naive thing for me is I wanted to be that person. One day I wanted to walk into a retail shop and buy a TV worth $20,000, $30,000, $40,000 with cash, which is a very naive child way of looking at things. And that's how the passion for money started. And that's where frugality started as well. We've always been very frugal, but me individually, I've always been extra frugal. and be very careful with my money. And that's how I've always, worked hard, saved as much money as I possibly could, particularly during my working life, and then invested very, very early. Of course, my views on money now is completely different. I'm not going to go buy a $40,000 TV, even if I could. I now realize that's a silly thing to do. But you can see how that got started when I felt that no one in the world could afford 40 grand. It turns out there's plenty of people out there who could afford that at that time.
Mm. And the idea of frugality, was that kind of something instilled by your parents, or was that kind of your way of kind of reaching a financial goal? Like what kind of made you embrace frugality?
I think very early in life, I learned that earning money, making money was actually quite difficult. And that's something my parents taught me very early in life. Every dollar that you spend is potentially a dollar wasted. And I say frugality rather than being cheap. I don't think we were very cheap as a family. And being cheap is basically chasing the lowest cost product. But I think my family were very frugal and very sharp in terms of what they spent their money on. Um, it was something that I observed from my family and my parents, and that's something that I've taken on board as an important skill. And also, my natural instinct is not to spend money. I'm a saver. So it's very easy for me to do that. I strongly believe that kids learn from their parents by observation, right? So my children are probably observing what I do, what my wife does, and they learn from that. And frugality is something that comes up all the time, even in my family as well. When we go on holidays, when we want to spend money, my kids don't go for the most expensive option because they've grown up knowing that the value of money is really important. So I think it's a combination of instincts and inherent behavior, and also the environment that you grow up in and the observation that you do with people around you, such as your parents, who are going to be the role models when it comes to financial habits.
Yeah. And I don't know if you had any siblings. Did they also kind of have the same kind of mindset in regards to frugality? Or because you hear
Very,
of interesting stories how sometimes, same parents, but then, one child becomes more of a spender, one becomes more of a saver.
yeah. Look, I do have a sibling, probably not as frugal as I am, but still very much an investor, still very much a saver, but certainly spends a little bit more money, and probably spent a little bit more money during the younger times than I did, but still very much in the league of has done well for himself. But yeah, very similar, but probably not as intense as me, for example. Yeah,
Yeah.
for me that intensity really was whoever that lady was. She'd probably be in her 80s right now if she's still alive. I have to say thank you, because that one moment completely changed my perspective on money and life. In David Jones in Adelaide. I don't even know if that store still exists, but hope it does.
Yeah. And I guess shifting forward a bit, tell us about kind of high school. Did you have any part-time jobs? And then also why you chose to study medicine?
Yeah, so high school, public school. Shout out to Unley High. If anyone's from Unley High, great school. In Adelaide, I think that was one of the privileges that I had. Schooling was not really a big deal. Most schools were generally pretty good. I think in 2025, that may not be the case. Certainly not the case in Sydney and Melbourne, where you live determines what school you go to, and what school you go to really determines what level of education or quality of education you get. But in the 90s, education at Adelaide was actually fantastic. So I didn't go to a private school, didn't need to. Went to a well-reputed public school. I was within the zone. So that's number one. Why medicine? Well, I mean, I'm not going to say it's the first generation immigrant thing to do, but it is the first generation immigrant thing to do, right? If you have a look at a career that can completely change um, a lifestyle and income and wealth in one generation, I'd have to say health sciences like medicine, dentistry would be up there. Um, there's not many careers out there that would change people's lives in that one generation. The average sort of work for income sort of generation. I'm not talking about entrepreneurs, etc.
Mm.
But I just felt in the 90s, the people around us, the people that had stable income, stable safety, reliable lifestyle, fairly wealthy, were the doctors and the dentists. and I wanted to reach financial independence reasonably quickly. And also, I wasn't averse to working hard. I did notice that a lot of our family friends who were doctors and dentists worked really hard. Some of them worked, 6, 7 days a week. I wasn't averse to that. I wasn't into this sort of lifestyle thing that a lot of people now talk about. So medicine didn't turn me off in terms of number of hours, hard work. So I sort of saw that and I went, well, it's probably the most reliable career that I can fit into. And that's how it all kind of started. I wasn't really, I'm not going to lie and say that I wanted to help people and treat patients and, work in a, really difficult environment. Yeah, look, all of that is just part and parcel of being a doctor. That wasn't the primary aim. The primary aim is, realistically, I wanted to be in a space where I can communicate with people, I can earn a good living, I can provide for my family, and have a pretty well stable life. And I think medicine has offered all of those opportunities, and I'm really grateful to be able to get into med school.
Yeah. What would you say about, some people, some doctors kind of say, oh, the, golden age of medicine was kind of, a few decades ago, maybe 70s, 80s, where kind of doctors were more well respected and maybe higher income as well. And some people think the future is a bit more bleak, kind of in America, kind of managed healthcare or private equity taking over, less physician-owned practices. What would you say to that?
I think there is some truth to that. Now, I think if I was studying right now in high school, um, would I consider medicine as a career? It doesn't appear to be as attractive now than what it was back in the 80s or 90s, compared to other professions. Now we have other options. So, for example, like in my year of high school, the information technology age was just getting started. We really didn't have broadband or, smartphones or anything like that. Now you've got so many different options. So I tend to agree that it's probably not as sexy now to be a doctor than what it was maybe 30 years ago. But still, when you look around us, medicine does offer the highest income in terms of, if you look at the ATO stats, out of the top 10 professions, I think the top 8 or top 7 is something to do with medicine. It is a reasonably well-respected profession even today. It is a well-paid profession even today, but of course, it has a lot more annoying nature to it, like lots more paperwork than when I first started. I'm glad I'm not an intern now because the amount of paperwork those guys do is ridiculous. A lot more patient autonomous complaints. I mean, some of the complaints that I've received as a director of a department or as a chief medical officer of an organization. I mean, some of the complaints are just absolute nonsense. I don't think that those complaints would have even existed 30 years ago. I've had complaints where patients have said, oh, doctor took a glass of water during their shift. I'm like, really? Like, we're not allowed to drink water now? That's ridiculous. So we're in the age of, people just, throw rocks at windows all the time. So I tend to agree. It's probably not as attractive. It is still very much attractive. It still has a lot of options in terms of career, but it has a lot of disadvantages in 2025 compared to when I started.
Yeah. And it is interesting. I did do an episode about the, kind of how much do doctors earn. And one thing about the ATO stats, I guess it's like, taxable income. I guess there's some jobs, maybe say tradies that maybe a bit more cash in hand. Or say if you're a business owner and, there are, legal ways to kind of reduce your tax as well. But I think from one of your podcasts, maybe I think you mentioned obviously tradies enter the workforce earlier and maybe can build up investments earlier, but their longevity, I guess, of career, compared to say a GP, for example, GP might be able to work till their 70s.
Yep. Yeah. Look, I mean, let me give you an example, right? If you look at the tradesperson equivalent of a tradie in the healthcare sector, it's got to be orthopedic surgery, right? Very similar sort of, I suppose, in terms of intensity, early starts, long days, whatever. But an orthopedic surgeon competently could work as an orthopedic surgeon at the age of mid-50s, 60s, pretty competently and can possibly pull, up to $1 million of income per year. It's pretty hard if you're a carpenter or a bricklayer to work at that intensity at the age of 55 or 60. And I think this is what a lot of people don't understand, the longevity that medicine offers, because essentially you are using your brain most of the time, particularly in general practice, where it's a lot of mental stimulation. There's not much physical workload. I mean, orthopedic surgery is obviously both. That's a very good example to sort of compare. When people say, oh, tradies make a lot of money, actually get on the road at 5 o'clock in the morning. They're out there working. Whereas most doctors would probably start their day anywhere between, dare I say, 6:30 and 8 a.m., right? So it's hard work. And I think a comparison doesn't really hold true for longevity. Because I mean, I've never seen a bricklayer work at the intensity at the age of 60 because they're going to have, physical ailments. They're not going to be able to do it.
Arthritis. Yeah.
Exactly. Yeah.
Or
And
kind of
of course,
work-related injuries. Yeah.
and of course, a risk, right? Work-related injury, bad back pain. You've got a tradesperson. I mean, the number of injuries that I see, tradesperson, finger lacerations, tendon injuries, foreign bodies, etc., in the hands and feet. That's a risky profession. And I think that's what a lot of people don't understand. Yeah, you make a lot of money as a young tradie, but there's associated a lot of risk as well.
Yeah. On a side note, what do you think about, some people say, artificial intelligence, AI, it's going to take a lot of white collar jobs, even doctors. Some people say, obviously, doctors will be immune because of the human element or the medico-legal responsibility. Just curious what Dev Raga's thoughts are.
I think there's always some risks. So if you look at scribing software, I mean, a lot of doctors now use AI to take patient histories, come up with management plans. I use AI when it comes to administrative duties. Who's got time to read 20-page APRA letters? I can't be bothered. So AI would summarize that for you in 5 seconds. So there is a little bit of risk. I don't tend to buy this argument that AI is going to take over the world, because eventually what will happen, right, is that it'll be regulated. So, for example, they probably will say, if you got your advice from AI, that advice is not valid. You still need to see a human doctor to verify that advice. There are some specialties that are more risk than other specialties. I think procedural specialties generally are less risk because, by the time a robot actually does an independent operation, I just don't see that happening in my lifetime, competently with less injuries and risk. But could AI reasonably report on CT scans and radiology scans? Absolutely. It's already happening. So what might happen is one radiologist may be able to manage 4 or 5 radiology centers or 4 or 5 hospitals, rather than what's happening at the moment is one radiologist per hospital on call, right? So they might have an AI software read the scans, put out a preliminary report, then a human sort of just confirms or refutes that or changes it. That is a risk. So certainly radiology is up there. Pathology, could they automate interpretation of blood results? I think they could potentially automate that. General practice, the thing about general practice is this is where diversity comes in, because I don't think AI can mimic emotion, which is really what a non-proceduralist general practice would be really offering to their clients, right? So if you have a look at, yourself, Dr. Dan, or myself, Dr. Dev, why do people see Dev? Why do people see Dan as a GP? It's not because, I don't think it's because, Dan is a really smart guy who got 99.95 and knows all the antihypertensive. That's not what the patient wants. The patient wants to see Dev or Dan because of brand Dev or brand Dan, which I think AI can't mimic. So I think general practice is relatively safe, but with a caveat that you need to subspecialize. I think if you're a generalist general practice, I think you are very much, behind the 8 ball. I think you need to subspecialize. So GP proceduralist would be the way to go, in my opinion. Psychiatry, again, you can't mimic emotion. I mean, I don't know about you, Dan. Have you spoken to AI? I have. I've spoken to AI software. At the moment, it's not the same. It's not the same as me speaking to you right now. And I think that's what people would miss, the human element. So yes, there is some risk. I think the risk is overblown. I think eventually insurance companies will say, oh, we can't accept this advice because it was generated by AI. Just like your car, which is currently on autopilot, the insurance company will say, you as the pilot, you as the human is still responsible.
That's a good one. So we talked about why choosing medicine. How did you find medical school and then junior doctor years?
Yeah, med school was interesting, right? I did the traditional 6-year course, undergrad, as a teenager. I liked it. I found it relatively challenging in the third year of medical school. That was probably the worst year. And then after that, things just got easier. There's the thing about medicine I find, which is different to other degrees, I think, or maybe law's similar as well. The amount of information that you need to read and interpret in a short span of time is incredible. I can now understand why people do UCAT or UMAT exams and things, because there's so much information in medicine that you need to be able to digest very quickly and be able to interpret, master, and explain to the patient in a relatively short span of time. And med school in Australia teaches you that really well. I mean, you look at Robbins' pathological basis of disease, you need to read that from page 1 to page 5,000 and know it for the exam. So much information out there. I think law degree is probably similar. There's a lot of reading in that, a lot of summaries, a lot of interpretation. You just don't see that level of volume, I don't think, in other professions. So if you're a good reader, if you're quick at reading, if you can summarize things, I think medical school would be easy. And I didn't find it generally challenging, except for that third year. That was probably the most challenging year. Now, junior doctor years, I loved it, right? Because now I can make money. So being poor for 6 years as a med student, I couldn't wait to start seeing patients, learning medicine. I was extremely hungry as a junior doctor. When I say hungry, what I mean is I did not hesitate to work long hours. I often worked longer than average hours. I often was the first port of call for medical workforce if there's any spare shifts. So what I did was I did internship with RMH. Shout out to Royal Melbourne Hospital. I went to medical workforce and I said, look, any spare shifts, any overtime that you want to give me, anyone's annual leave you want me to do, any specialty, give it to me. I'll do it for you. And basically it became known at the RMH, if Dev was around, then he would be the first port of call to get shifts. And I'd do it. And it doesn't matter if I didn't know that much of a specialty like ENT, for example, or opthal. I'm happy to crack it. I'm happy to give it a go. And the reason being is I felt that I had my sound principles of basic knowledge that I could work across any specialty. And what happened was the 3 A's of medicine happened. I talk about this to junior doctors all the time. You need to perfect that. Number 1 is you got to be available. So basically, hey, medical workforce, I'm available. Number 2 is you got to be relatively affable. You got to be reasonably easygoing. People need to like you, because if you're hated, then that's it. It's end game in medicine. Patients hate you. Bye-bye. If your bosses hate you, see you later. The nurses hate you. Most importantly, see you later. The ward clerks hate you. See you later. So, people need to like you. You got to be fair, strong, like-minded. And then the last thing is you got to have the ability to do the job. So I would never back out from shifts that I've accepted. I had extremely low levels of sick leave. I can't even remember when I last took sick leave, to be honest. So those 3 combination, availability, affability, and ability, I mastered that really early on in junior medical school. As a junior medical staff. And that has propelled everything in life for me. Income, status, and therefore wealth, because you earn high amounts of money. So, let me give you some figures, right? As an intern, on average, back then, this is what, 2006, 7, right? 2007, I think it was. As an intern, I was easily at $130,000 back in that money. As a first-year resident, probably pulling around 150 to 180. As a second year, I became a registrar very early on. So I did internship, residency, and straight to registrarship. easily over 200, and then as a second year registrar, about 300. So I did that because I was able to master the 3As. And I think if you did that today, you could emulate that pretty easily. The only problem now is there's a lot of safe working hours issue. So you've got to be careful about how much hours you work, which is completely fine. But back then it was a bit more lax. So I was very privileged to be able to utilize that. And I totally exploited it to my advantage.
How many hours were you working in a week?
I mean, the thing is, I started off in neurosurgery, right? So, you know, as a neurosurgery resident, junior reg, you know, RMH, I mean, countless hours. Let me guess, easily 60 to 70 hours a week back then. Easy. I think even as a registrar, covering orthopedics, plastics, trauma, up to 80 hours a week. All of those were paid, right? So, worked quite a lot. And like I said, I was hungry. Like I'd be hanging around theatre rooms. Like I remember as a gen surge set trainee, I was scrubbed into orthopedic cases, and the orthopedic consultant was like, "Why are you even here?" I said, "I just want to watch." And he goes, "You can't operate in orthopedics because one, credentialing, and two, I've got an orthopedic registrar standing right here." I said, "That's fine. I'm happy to just watch." So I was just hungry, to learn more. And when I learnt more, I expanded my knowledge and I exploited that. Then I did a lot of rural work as well. And when you go rural, if you're multi-skilled, multifaceted, they love it. And they'll pay you for it as well. Yeah. I think it's still possible. I think it's possible. You've just got to be careful. And of course, I had an unusual appetite for work as well. And I was healthy. I didn't have any health conditions. And I was very lucky. I was able to work long hours without breaks, which again, if you can do that, if that is your thing, if you can exploit it, then do it if it's safe to do so. But it's not for everyone.
Yeah.
It's not something that I wouldn't recommend people work 80 hours a week.
Did you come across in your junior years, did you come across any other doctors that had that similar drive or?
Yeah, I was surrounded by people very, very similar, very passionate, hungry people, predominantly in the surgical field when I first started. And it was much easier. Like Dan, when you're in high school, you want to reach your peak performance. And the way you reach your peak performance is you've got to surround yourself with people that think like you. Even now, even as a consultant, we call it the metabolic group. The metabolic group basically evolved a group of about sort of, 5 to 7 people, very like-minded, unusual appetite for work, unusual appetite for savings, unusual appetite for investments, unusual appetite for career diversification. And we just, every quarter, we sit around, have dinner, discuss, we learn from each other. And there's a, combination of GPs, administrators, other specialists. If you surround yourself with people like that, it just makes it a lot easier. If you do not have people like that, then it's going to make life difficult. So again, I was very lucky. I had all the stars aligned. People generally liked me. I'm very grateful for RMH and Monash when I transitioned to Monash Health in Melbourne. Very grateful for my mentors who really supported and cultivated my attitude to work and my attitude to life, as opposed to being surrounded by people who are relatively negative. That's not going to work. And I tended to avoid people like that. And look, in medicine, as you know, there's people like that all the time.
Yeah, I think that's, excellent outlook. And yeah, I think there's a saying that you either do the hard work now, so you have an easier life in the future, or have an easy life now and your future life will be hard.
I agree. You can't have everything, right? You can have anything in life, but you can't have everything. So, I mean, I speak to a lot of junior doctors who are like, "Hey, Dev, I want to work 9 to 5. I want to make $3 million a year." Well, it doesn't work like that. Unless you're a super whiz that's invented something and has multiple businesses, it's not going to work, right? So what I decided to do is work very hard early in life, invest a lot of money. So therefore now, as I have a family and kids in school, I can work less. and I can work in a more of a, like I said, most of my work is work from home, work in a flexible environment. And I don't have to be on call and do night shifts and this and that. You know what I mean? Whereas if I had not done that early on and I didn't have the financial backup now, I may have to do it now, which is for me, I didn't see that as a option because I want to be home with my kids, with my family, particularly when they're at schooling age.
Yeah. And that's probably transitions to my next question. So you were in surgical training. What made you change and do general practice?
Yeah, good question. So this is interesting. I don't think this is actually allowed anymore. But what I did was when I was a set trainee, I actually did general practice training on the side. I don't think you can do that anymore. So shout out to RACS and RACGP. I played both colleges. Hey, you fell for it. Nowadays, I think you can only do one college training. Look, after a while, I sort of decided a couple of life events, and I went, you know what? What am I achieving here as a surgical trainee? The amount of hours and the income per unit time and the lifestyle, I've sort of figured it wasn't sustainable moving on to your 30s and 40s and 50s. So luckily, because I did general practice training on the side, I switched pretty easily. And here's the thing, the big but, all the skills that I learnt as a surgical registrar, I basically implemented in my general practice career and diversified my specialties, and that boosted my income. Let me give you an example, right? And I owe a lot of my financial success to my surgical life, and I'll tell you why. Being a surgical registrar is like being a general manager or CEO of a company. You need to manage people around you. So manage your interns and residents, manage the nurse unit manager and the nurses, manage the allied health staff. You need to manage your immediate supervising consultant. You need to manage the director of the department. Then you go into the emergency space. You need to manage your emergency colleagues because that's where the referrals come from. You need to manage theatre. That's a whole different ballgame. You need to book theatre cases, negotiate, manage your orthopedic colleagues, plastics, your obstetricians. Hey, I want to do my case before you. This was dog eat dog back then, right? I mean, I was at RMH and also at Monash. You go to any theatre complex, there's a theatre num and a theatre anum that decides what cases go first. There's an anaesthetist that you need to manage, the anaesthetic registrar. I think it's pretty hard to find a specialty where you would need to manage so many people in a dynamic, short, successive, efficient way than surgery. I know this sounds very biased. I just do not think personally there's another specialty where you would need to manage all these people in a very cutthroat, difficult environment. And let's face it, surgery is cutthroat. The entrance is cutthroat. The fellowship exams are cutthroat. It is a dog-eat-dog world out there. I remember. Actually, it's a pretty funny story. As a set trainee, general surgery trainee, trying to get patients in for a laparotomy, I would negotiate with my orthopedic and plastics colleagues and call the consultant and say, "Hey, look, I'm sorry, your hand fracture has to wait because my laparotomy is sicker than yours, and I had to prove that my laparotomy is sicker than yours." And every day, it's like that. I don't know how it is at the moment, but certainly back there, it was like that. So what I then did was all those negotiating skills, the communicating skills, the people building skills, the people management skills, I just incorporated that into general practice. So in general practice, who do you need to manage? The practice manager, really important. You can't piss them off. Your practice colleagues, your practice nurses, your practice receptionists, your GP registrar colleagues. If you can manage them and make them work for you at their most optimum level, then automatically your income goes up. Because when you think about it, who is the most important person as a GP? The most important person, in my view, is the receptionist, because it's the receptionist that keeps your books full. So don't piss off the receptionist. So I had this unique capacity to be able to analyze a situation and come up with a formula. And I just executed the same formula. Who's the most important person in surgical life? It's the theatre anum. They control the theatre flow. So if you can convince the theatre anum that your cases are always more important, then everyone else is going to be a lot easier to fall in line. So essentially, I utilized all those skills, switched to general practice, and just exploited those skills in general practice, which surprisingly a lot of people don't have because they haven't been through that sort of previous training experience. And basically my billings went from, when I started, I mean, this is back in, over 10 years ago. I was billing $3,000 back then.
Wow.
Because I was able to efficiently manage my work and my practice manager, my receptionist. And we had great fun. It was great fun to do it. But after a while, I really didn't enjoy the billing side of things. And I sort of felt, $3,000 a day, was it? I thought, well, that's not going to be my max. I want to do a bit better. So then basically subspecialize in other areas. Yeah.
In that GP clinic, was it like a small clinic or was there heaps of other doctors or?
Yeah, reasonably mid-sized, probably only about 4 to 6 GPs from memory.
Yeah.
Um,
And how did you, I guess, often, maybe it was different back then. I know sometimes there's a lot of turnover of reception staff. Was it just kind of, as you said, communicating and kind of using your social skills to kind of, essentially win over the receptionist and try and keep your books full, or and also process the billings correctly? Were there any tips that you could give our
yeah,
GPs?
basically as a GP, Dan, you're building a brand, right? So basically it was brand Dev Raga from 8 o'clock in the morning to whenever I finish. And that brand permeated through the receptionist staff, the practice manager, the GP colleagues, the registrars. And I worked across sort of multiple clinics. I found that, again, utilizing the 3 A's of medicine, having a pretty good work ethic, having solutions to problems, introducing new things, which improves practice efficiency, improve their billings. Let me give you an example. As a GP registrar, I negotiated with an aged care company on behalf of my boss, which brought potentially around $300,000 to $400,000 of extra billings per year.
Wow.
That's money they didn't have, right? Now, you got to be careful. Your boss has to be flexible enough in order to listen to a registrar. I had a phenomenal boss who was very open to new ideas and how to change the practice, how to improve things. And I was able to do this. If your boss is very closed-minded and doesn't want to try new things, there's no point going to them. So I sussed out my boss and I realized that she was fantastic. Shout out to her, really instilled some really good billing practices and also really instilled some really business practices in me early on. And I went and said, hey, look, why don't we do this? Why don't we subspecialize in a bit of an aged care? And she was already had a huge aged care cohort. And I said, why don't I bring you this extra nursing home, which is around 180 residents, which is around $400,000 of extra work and extra billings. And she was like, well, what's the downside? Well, the downside is zero, because it's basically patients that need care. We were experts in providing the care, and she gets an additional $400,000 in billings in terms of total billings. Of course, I then negotiated after that. I said, well, hang on. If I'm going to give this to you, I'm not going to utilize your GP practice space. I won't settle for 60%, right? Maybe I want 70, 80%, right? So, we sort of settled for that 70 or 80. I can't remember, 70 or 80% of those billings. To be honest, if I was a consultant, I'd probably negotiate 90, 95%, because basically the GP clinic, there's nothing to lose. It's basically free money that they've made. And my boss was phenomenal. She said, you know what? You're absolutely right. You're bringing in this $400,000 of income. I'll give you, I can't remember, I think it was 75, 80%. I can't remember exactly. I'll give you a higher percentage for your nursing home work, and for your GP work, I'll give you this. So I believe that I had a pretty good team, and again, very lucky. But also I'm smart enough to not go to people that I think won't be good value for me. It's about choosing the right people. If you try and install this in everyone, it doesn't work. And you've just got to be able to pick the right person to be able to approach them safely and securely. And as a registrar as well, you've got to be very careful, because you don't want to piss anyone off as a registrar. It doesn't matter what specialty, because ultimately medicine is an apprenticeship. You piss off your bosses, then life can be very, very difficult. And that's just being frank and honest, to be honest.
Yeah. And with that 400,000 billings, was that kind of in terms of attendance numbers, or was there some sort of like incentive from the government paid to the clinic? Like, and what was involved? Like, was it kind of weekly visits, or did you have to be on call 24/7? Or
No, it was twice weekly visits, 180 residents, entirely managed by myself. And of course, with aged care medicine back then, it was a real gap in care. I think even now there's a huge gap in aged care. And strangely enough, I enjoyed it. I really loved dementia management. I loved palliative care medicine. That's when I did extra training. I refined my skills in communicating, because communicating with family and friends on a daily basis when their loved one's dying can be very different. So that basically is how I got extra training in that area. And generally speaking, in aged care, I mean, back then I sort of calculated, $3,000 a year per resident, which is 180,000 times by 3. It's actually more than 400,000, probably more than that. That's how it sort of happened. But I think these patients deserve care. I strongly believe that people in aged care deserve good care, and there's no reason why they shouldn't get access to good care. And I was a good GP, and I was willing to learn aged care, which a lot of GPs at the time were not willing to do. So therefore I was rewarded for it.
How do you find aged care back then versus now? I think there's been a lot of changes, Royal Commission, and anecdotally from some of my colleagues working as a nursing home GP, kind of, need a documentation or doctor to sign off on, chemical restraint, or, charting, random stuff like, I think I remember it was a med student that, have to chart, their nightly wine, or something like that. And then also maybe some unrealistic demands either from the aged care facility or families.
Exactly. So we very quickly, I very quickly developed a system. So basically, every patient gets an advanced care plan within a week of arrival. Okay, that's number one. It still is not being practiced even to this day, because advanced care planning and the time it takes is not billable, right? Unless you actually clinically treat someone. The Medicare benefit schedule is so crap. It doesn't actually take into account organizing an advanced care plan. But that was something I felt really passionate about, so that you set the standards. This is the goals of care. This is what we're going to do. We would do case conferences twice weekly, 5 case conferences per day, so 10 case conferences a week. And we would do care plans I think it was every 10 weeks from memory, so 4 or 5 care plans a year. And also, of course, you've got the RMMRs, you've got the CMAs, etc. If you did all those, what I noticed was the incident level with my residents was lower than anyone else. That's number one. Number two is, when your incident level is less, again, brand Dev Raga, the nurses in the aged care preferentially prefer me to be the patient's GP, because they think, and they are right, that the care is phenomenal, right? It all comes back to clinical care. So once you institute a system and a structure, and you bring along the nurses with the journey, you provide the education with the nurses. So for example, falls review, okay? It's a very common aged care problem, even to this day. Every fall needs a medical review, thanks to Royal Commission. Some of it is nonsensical. Actually, if you can train your nurses on how to assess falls and how to prevent them and how to harm minimize them, and there are protocols in place to do this, over time, the number of falls actually decrease. And if the number of falls actually decrease, then you're providing good care, you get more residents. And guess what? In that nursing home, a lot of the existing patients who had different GPs would turn around and say, well, hang on, Dev Raga's here twice a week on the dot without a fail. My GP sees me once a week, measures my blood pressure, bills me whatever the bill that is. What's the point? I'm going to switch. And in fact, eventually, that's how the entire 2 nursing homes basically came across to my care. And then, of course, you've got to have a system to manage family members, and being open, transparent, and have a clear line of communication and involving them in the decision making, and also being really realistic. Okay. So just transferring aged care people to hospital is an absolute disaster, because hospitals are dangerous places for elderly people. I can tell you right now, the emergency department is the most dangerous place for an aged care resident to be in if they don't need to be there. Okay, so we develop policies and protocols for things like falls, suspected head injuries? What do you do with warfarin? Back then, warfarin was very prevalent. NOACs and DOACs were just coming on board. So have some plan in place, because if the patient is not really fit for certain things, then they may not need to go to hospital, but they may be suitable for residential in-reach. Of course, you are always going to have difficult families who are struggling because they're grieving. Let's face it, their loved ones are dying and they're really finding it hard to cope with that. But it's all about a systems-based approach. And guess what? Where I learned that from? From surgery. When you do surgical training, everything is systems-based, right? Trauma call, airway, C-spine, breathing, circulation. Emergency medicine, also very systems-based approach. So essentially, I instituted systems. Therefore, that translated to better care, less risk mans, less adverse effects, better brand, and more billings, better satisfaction, and reduce problems with family. But unless you have a system in place in aged care, if you think that you can go to aged care and just see patients once a week and not be responsible for the other 6 days, it's not going to work. You've got to have a system in place to be able to handle the after hours.
Yeah. And why do you think kind of over the years, kind of it seems less GPs are interested in aged care work, or maybe not exposed to it? Because I know, ages ago, you'd have a GP, cradle to grave medicine, do home visits, do nursing home visits. Now it'd be extreme minority, I would think. What do you think might be contributing to that?
Depends on the personality of the GP. Some GPs just want to sit in the office and see coughs and colds all day, which is completely fine. Some GPs like to see complex mental health, which is completely fine. Some GPs like aged care medicine, which is complex mental health, psychosocial behaviors, clinical medicine, family, advanced care planning. That's completely fine as well. But I'd have to say the reason why a lot of GPs are put off by aged care is because it's perceived to be complex, and it is. And also, let's face it, aged care is chronically underfunded. I mean, the government has systematically underfunded aged care, privatized a lot of aged care homes, which I mean, you'll see. I mean, I worked across public and private, and the public aged care homes were very well run. Today, you'll see some of them in the rural areas attached to a hospital. Nurse ratios, staff ratios, PCA ratios are amazing. The privatized ones, depending on which private company runs it, is abysmal. So it depends on which aged care home that you work in. But I think generally they've made it very unattractive because of what you said about nonsensical policies, thanks to the Royal Commission, which really puts the onus on the doctor. Everything needs a medical review. Really? To chart wine on a drug chart needs a medical review? That's ridiculous. So as a result, the perception is aged care work is complex, too difficult, underfunded, under-rewarded. But even today, if you structure it, and this is where AI comes in, so scribing, for example, some aged care doctors have overseas scribers, some have AI. If you can cut down the bureaucracy of it and outsource some of it, it can be worthwhile. But I'd have to say it probably is more worthwhile if you do aged care work for yourself rather than through a clinic, because a clinic will take 5 or 10% of your billings, whereas if you do it yourself, you get 100% of your billings, and you keep more of what you earn. So if you can, if you have an office, if you have a partner that can do all the billings, if you have a scribe overseas or AI, if you have a system in place for care plans, case conferences, after hours work, etc., it can still be worth it, but you need to have that system. Otherwise, I agree, it's a very complex, and people are put off by it, to be honest.
And I think even for nursing staff, I think often there's like one RN for the whole facility, and often relying on, AINs or assistant in nurses, and kind of the RN is kind of almost like a managerial rather than seeing the patients. And also, I think another common gripe from GPs is, they might turn up to the nursing home and, hard to find, documentation or where the staff is. And it might be, locum or agency nurses filling in, which is a bit sad. And
Correct.
also, yeah, I think ideally if the government did fund aged care a bit better, it'd be better.
Correct. And you'll see this between public and private. So a lot of these problems, I have to say, my experience when I've worked in a private aged care facility can be quite problematic. The way I avoided that was, again, it all comes down to systems and structures and negotiations. Everyone knew that on a Tuesday and a Thursday, Dev Raga will rock up on time at this time, and the expectation is they're ready to go. Where did I learn that from? From the hospital system,
Yep.
right? So again, goes back to my hospital experience, goes back to when I was doing surgery as well. My intern, shout out to all of my interns. I was really nice to them, but they knew at 6:30 in the morning, I like my half strength latte. It's got to be ready to go. That's just the way it is, right? Now, if you're an intern, that is not an expectation anymore, but certainly back in the day, that's how we, some days I'd pay for it. Other days the intern would pay for it. Payment is not the issue. It's the fact that the ward round starts at 6:30 in the morning, Monday to Friday, and Dev Raga will be there, and you better be ready to go. The same works out in nursing home as well. On a Tuesday and Thursday, they all knew that I'm going to rock up on time. And by the way, I'm never late. That's the other thing. I'm on time. So that way, it's a reliable mechanism for them to say, okay, at 9 o'clock he's going to rock up. We better be ready. And you set the expectations. I think if the GPs did that more often, a bit more reliable, then I think they'll notice the overall experience is a bit better. Again, a lot of those skills I learned from hospital.
Yeah. And kind of a tricky one for everyone, inside and outside of medicine. How did you juggle kind of medical career, investing, and then also, raising a family as well?
Yeah, to be honest, during my junior years, it was pretty much made loads of money, saved around 70%. Again, 70% of 300,000 is a lot of money. We didn't spend much money. We didn't have lavish holidays. We didn't, kids didn't go to, they've been going to private school most of their lives, but not when they're babies. A lot of people enroll their kids in early learning centers. We didn't do all that. So how did I balance it? It was, look, as a surgical registrar, as someone who worked quite a bit, there was no balance really. But again, like I said, you can't have everything. You've got to make sure that if you're going to be working 5 or 6 days a week, then the 7th day is rest and family day, and however you structure it. I had a very robust family who were very supportive. And of course, this is, when kids are young, predominantly my partner doesn't do paid work. So she's a homemaker, very supportive. So I had the support and structures in place around me that helped me do what I did. But it wasn't easy. And look, basically, in terms of investing, if you save 70%, I very quickly learnt that as a young person, the biggest impact that's going to affect my wealth long term is my savings rate. It is not my investment return. This is something a lot of junior doctors get wrong. They're hungry for investment returns. Actually, it's your savings rate. And here's why. If you save 50 to 70% of your income every single year, no matter what investment you do, you're not going to get 70% return, right? So already you're beating the market just by saving that much money. And that is something I learned very, very early on, and basically plowed all of that into super and index funds. Back then, I didn't buy any crypto or anything like that, nothing unusual, bought some property. And can you imagine doing that for over, 15 years or so? It just compounded returns. It's as simple as that.
Yeah. I think on the forums, a lot of doctors ask, should I put in this ETF or, this share and, save, change my mortgage 5.7, 5.6%. But yeah, I agree. I think one of the most important things or factors is your earnings rate, and then also your savings rate, because if if someone saves 80% of their money, someone else saves 5%, that's multiples of times of difference.
No comparison, right? I speak to a lot of multimillionaires, most of them healthcare workers. Never once has someone said, I became a multimillionaire because I got a 0.5% reduction in my home loan rates. Those are all minutiae. That's just very small amounts. Yeah, 0.5% here and save $1,000 here or there. But pretty much everyone says to me, I saved heaps of money. And pretty much everyone says to me, I invested most of that money. That's how they became multimillionaires. It's not the fact that they saved 0.5% in the home loan here or there. That's all minutia. No one ever says to me, I became a multimillionaire because of credit card points. It just doesn't happen. So focus on the big stuff. Get educated, earn loads of money, work hard, save loads of money, invest it early. And 99% of the time, that's all you need to do. It's not your Cayman Island Trust Fund that's going to save you.
Yeah. And moving on to investing, how young were you when you started investing, and has your investing philosophy changed over the years?
Not really. I'm a very boring person. So I pretty much invested straight from internship. Prior to that, I saved about $40,000 of the medical
Wow.
student over about 6 years. That was my deposit for my first home. So you can imagine where my savings comes from. So I bought my first home very early on in my career and paid it off within 2 or 3 years.
Wow.
So again, if you buy a home for, I think my first home was $390,000. If you buy a home for $390 and you're making, 180 to 300, it's pretty easy to pay it off pretty quickly. And yeah, basically just invested in broad-based index funds and maximized my super the entire time, and just rinse and repeat and reinvest my dividends. And basically until I reached, I think the first sort of 7 years or so, I went, oh, what am I doing here? I'm actually making any money. But then as soon as you become that net worth million in your bank account, in your investment account, that's when things start really ramping up. And you do projections on that and you go, oh, okay, well, if I did this, this is what I'm going to achieve in the next sort of 20, 30 years time. So I started very early on in my 20s, and I'll keep doing that till I retire, and probably do it in my retirement as well. Probably just save 20% of my retirement fund and just keep reinvesting. So it's a very, very simple formula. And like I said, I was lucky enough to learn this very early on, be very consistent and not waver and not get distracted, which I think is the biggest issue at the moment. I think a lot of people just get distracted, forget to do it, or, go spend their money on a new car or buy a house too big that they can't afford, all that sort of stuff. I just was able to keep it very, very measured, very easy, very simple.
Yeah. And from your podcast, you talk about, kind of evidence base. Do you want to expand a bit more that? Is that kind of the idea of index funds generally outperform kind of managed funds or stock picking and things like that?
Yeah, exactly. I'm very much a passive investor. When you think about what an index fund is, particularly when it comes to top companies and market capitalization indices like the ASX 300 or the S&P 500, mathematically, at any one time, you're always going to have the top companies in that index. So you'll never really invest in the bad companies. There'll be some of them might be underperforming a little bit than the other one, but overall, it is the best companies out there. And you can do it globally as well. You can have the Russell 1000 index, for example. You have the top 1000 companies in the world. And the evidence is when you own the best and brightest, where everyone from the CEO to the cleaner is working hard in those companies to make me rich, you can't really go wrong when you think about it, unless the entire economy crashes around the world all at once and never ever bounces back. Now, that's the other thing I learned very quickly, is that when that happens, as did happen in GFC 1.0 and 2018, I think it was, and 2022 and 2020, and more recently due to the tariffs and all that, that's great, because you keep buying, because over time, these 300 or 500 companies will get bigger and better. And the other thing I learned about index funds and the evidence is it's a self-cleansing mechanism. And Jim Collins talks about this. Basically, the top company 100 years ago is no longer the top company in 2025. And the magic of the index fund is that it keeps getting renewed and the top companies keep coming out. So a classic example of that happened in the ASX 300 in 2020 when COVID hit and people couldn't travel and Virgin went bust. Virgin was part of the ASX 300, but it was only such a small amount of my portfolio. I didn't even feel it.
Mm.
And then Afterpay come into the ASX 300 during that time, and Afterpay really did really well. And all of a sudden, I lost some money in Virgin, but I made a lot of money in Afterpay, and everything kind of equals out. And that's the evidence. If you look at, there's a website called Spiva.com or through the S&P Global website, and they go through every single continent, Africa, Middle East, India, Asia, Australasia, North America, South America, and the evidence is overwhelming. Over time, the index funds over the long period of time, 100% of the time, or most of the time, do better than the active investors, because it's not the same active investor that is consistently beating the market. That's the other thing. That's the other lie that people don't tell you about. If someone tells you, I beat the market in 2024, my next question is, what did you do in 2023, 2022, 2021, 2020, and 2025? Did you beat the market every single year? And most investors won't be able to do that, bar a few, like Warren Buffett or the late Charlie Munger. But we're not Warren Buffett. We're not Charlie Munger. We're doctors. So we just don't have time to do that. So that's why I think the evidence is very clear. And again, I didn't lose sight of it. Save loads of money, play it into index funds, rinse and repeat. And basically it's worked out really well.
Yeah. And do you do it kind of automatically, like a dollar cost average, and every paycheck kind of set amount, kind of, so it's all automatic?
Bingo. Absolutely. Tuesday night I get paid, which is tonight. Tonight's Tuesday night, I'll get paid. On Wednesday morning, 20% of that money is gone straight into Vanguard, straight to my index funds. It's automated. I'm with Commonwealth Bank. It allows automation. Vanguard allows automation as well. It's very simple. Just like super, right? When you think about super, it's automated, right? Your employer pays into your superannuation fund every fortnight if you're an employee. So, as an intern, as a resident, if you're listening in, you should be getting super. From July, it's going to be 12%, just like that. You just do it, just automated.
Yeah. And what are your thoughts about a lot of doctors kind of interested in, and one of the most listener questions they ask is about self-managed super fund? What are your kind of personal thoughts on that?
Yeah, look, I don't have one. I think it's completely fine if you wanted to have one. The only advantage of self-managed super fund, when you think about it, is if you wanted to get assets that are not available in your industry super fund. Like if you wanted to own a property, a specific property, then self-managed super fund is useful to do. I was offered that option. Again, I can't be bothered owning individual assets. I just stick to index funds, and I've just stuck to my industry super fund. So if you wanted to get something very, very niche, like a practice within an SMSF, or property within SMSF, or paintings or cars within SMSF, yeah, that makes sense, because you can't access those assets in your traditional retail or industry super fund. But for most average people, including doctors who on a PAYG income, I think it's completely fine to just stick to the basics and keep your fees low and stick to an industry super fund, or whatever super fund that you want that has the assets that you have that you can invest in, and keep it broadly diversified, and max it out as much as you possibly can. And to be honest, is there legislative risk? Yes, there is legislative risk. There's legislative risk in everything. This whole $3 million cap thing that the Albanese government may bring it in July. Yeah, look, am I going to be affected by it? Absolutely. Do I really give a crap about it? Not really. Because again, I'm a 47% taxpayer. It's still going to be beneficial for me. So I'm not really that worried about it.
Yeah. And what about other asset class like property? And I think you said you did have some property. I guess going forward, some people think that, kind of more taxes on property and shares might be less headache. What are your thoughts about, index funds, property?
Every year in Victoria, I'm paying $21,000 in land tax.
Well,
right. So my Vanguard portfolio has never sent me a bill for land tax. So yes, I do have some property. I'm not going to buy any more investment property because my investment property, my Vanguard portfolio never asked me to fix the plumbing.
Yep.
It's never late to pay me dividends. It's cheap. It's effective. I don't have to deal with real estate agents. And I've learned that as I get older, I want to keep things simple. So I don't want to be a 65-year-old trying to manage trying to manage tenants. I just can't be bothered. So yeah, property's done really well in Australia. It's a great asset class. I just don't think property will crash in Australia. But it is a pain in the ass. So over time, currently my portfolio is 50-50. My target allocation is going to be 75-25 when I retire.
Oh, okay. As in 75% index
Equities.
funds and 25%
Correct.
property. Okay.
Correct. Yeah.
Yep.
And that 25% property is probably going to be my principal place of residence, to be honest.
Yep.
But at the moment it's 50-50. Yeah.
Yeah. I can attest to that. Kind of recently had to replace all the air cons for, I think it was $9,500 for just one property. So it can be painful.
It's
Uh,
just painful. Yeah, it's annoying, painful. But again, it's emotional. When I drive past my investment property or my own home, I feel good about myself because it's mine, it's tangible. I can see it, I can touch it, I can feel it, I can smell it. When I log into my Vanguard portfolio, I don't get the same emotional impact. Yeah, I just see a bunch of numbers and I'm like, well, yeah, it doesn't really affect me as much. And I think that's one of the advantages of property. If you're into that sort of stuff, if you want to actually feel it and smell it and touch it, then yeah, property is good.
yeah. Finishing up, do you have any particular end goal with your investing? Any kind of broad terms like a passive income goal or portfolio size goal?
Yeah, good question, right? Generally speaking, um, I've been very fortunate to have a very high income. So, you know, I've got more than a seven-figure income right now. I've had a more than seven-figure income for a while now. So if I was to have a target, I'd want to have at least 60 to 70% of that in passive income when I retire. So that's in the next sort of 20, 25 years, around the 600 to $700,000 a year mark. Now, if I'm half wrong, I'll settle for 300 to
Yeah.
350, right?
A lot
So
of
I
Australians
have
would. Yeah.
that's right. So I have this sort of half wrong principle. So I think, you know, let me answer that question this way. Would I make 100 million in portfolio? The answer is no, right? I'm well past the seven-figure mark at the moment in terms of portfolio. Um, if I played my cards right, I probably would make 50 million. Um, but I've realized as I get older, I want to relax a little bit, have a bit more lifestyle, spend time with kids. And for me, I'd be happy anywhere between 20 and $30 million, which I'll make. So, and if I'm half wrong, I'm happy with 10 to $20 million, right? Um, so that sort of gives me a sort of a figure of about sort of 600,000 a year in terms of income, for my portfolio to never expire. And also have some money left over to hand over to kids. I'm not really doing this to, do legacy wealth. I'm not into that sort of stuff. We spend a lot of money now on holidays. I think last year we spent easily a couple of 100,000 on
Oh,
holidays.
wow. Yeah.
This year we're probably on track for about 100,000 on holidays. So we spend a lot of money on things now. Even despite that, I reckon I'd probably be comfortable at $20 or $30 million portfolio with about $600,000 of passive income a year. I'd be pretty happy with that. And if I'm half wrong, I'm happy with 300,000 a year.
Yeah. And what are your thoughts about, some people will say, oh, I want to create a, multi-generational wealth, build a legacy. But then other people say, look, I don't want to take away my children's, drive or ambition. Yeah, what are your thoughts on that?
Yeah, I'm not a legacy person. My parents weren't legacy people. I'm not into that sort of stuff. If you're into that sort of stuff, that's completely fine. I don't have anything against it. Um, But I feel that, it's my money. We worked very hard for it. And I think me and my wife should be able to enjoy it as much as we possibly can. And I think the best thing as parents that we can give for our children is safety, security, housing, food, clothing, and education and healthcare. If you can achieve those for your child, those are the tools that they will use to build wealth themselves. I think that'll probably be more personally satisfying for them as opposed to just get given $10 million when they turn age 25. Yeah, I'm not legacy wealth building sort of person, but if someone wants to do that, that's completely fine. And certainly need to see a will and estate planner if you want to do that,
Yeah.
given potential death taxes and all that sort of stuff.
Yeah. And do you have any kind of items on bucket lists, like, things you would like to spend money on, such as a supercar or anything like that?
Yeah, good question. Look, this is a sort of famous metabolic meeting thing that I told one of my colleagues. All I want is a nice house, possibly one supercar, one nice car, and possibly two or three holidays a year. That's what I'm
Hmm.
sort of aiming for in retirement. I think what I've now realized is experiences are probably worth a lot more. Hence the holidays and
Hmm.
spending time as much as we possibly can. So certainly, if I was to, I probably would renege on the supercar. If I can afford it, I probably will do it. But if that means that I can have extra couple of holidays a year for the rest of my life, that's probably the way
Mm,
that I want to go. Because I think when you go to other countries and experience their lifestyle, their culture, that actually enriches you as a person. You can come back and implement some of the learnings in your own life. That's what I've realized, more and more. Um, but certainly want to live in a nice house though. Like I'd want to live in a nice independent house, in my retirement as much as I possibly can, because the chances are that my kids will probably need me to support them
mm.
during their education. When they get married, maybe they want to move in with us. I mean, I'd love that if they wanted to do that. That's completely fine. I mean, culturally, I'm Indian, so a joint family is not an unusual concept in our culture, but I wouldn't expect them to do it. But if they wanted me to do it, Dad's still around to help them out, because that's part of my role.
Yeah. And I know you talk to a lot of doctors, GP, and also non-GP specialists, kind of like clarity calls, and you're just kind of seeing some common issues or common themes. What are some common themes and kind of challenges facing doctors, especially say earlier on in their career, kind of training or just post fellowship?
Yeah, it depends on the type of doctor. So when I speak to consultants, the number one risk that I see with all of them is inertia. They always want to get started. They have all the right thought processes, but the problem is they never start because they get the paralysis of analysis, they get confused, they think it's all very complex, and they actually earn loads of money and don't know what to do with it. And what do? They have incidental expenses, have children, private school fees, expensive houses and cars, and eventually don't have any money to spend. So inertia has to be a common theme at the consultant level. At the junior doctor level, my biggest advice that I give everyone is always have a backup plan, right? So one of the issues, one of the risks of medicine is that if you spend so much time and effort into one subspecialty, one
Mm,
career, and for whatever reason, you don't pass the exams, you have a health crisis, you never get into the program, that is a huge risk. That is an opportunity cost that you can never get back, and that's time. So always have a backup plan. Always think about what happens if this fails. Where did I learn from? I learned this again from hospital training and surgical training, because when you prep for these operations, that's always running through your mind. What happens if I get into this abdomen and I'm not able to solve the problem? What's my get out of jail card? What's my backup plan, right? So for junior doctors, when I talk to them and I do these clarity calls, most of it's about career choice. And most of it's about what they want in life, what they want to achieve, their income expectations, their passionate, what they're passionate about, etc. So really hone in on that and try and have a backup plan. And of course, get started early. I mean, this is probably the number one thing that I noticed, that people don't get started early because they think that having a little bit of money earlier in life is not enough. So they wait till they become consultants, their income explodes, and therefore that's when they start investing. If you're a training surgical registrar, it's going to take you 10 to 15 years time. You're going to be late 30s, maybe even 40s by the time you're a consultant. That's 15 years of opportunity cost. And I think that is what I did really well. I recognized the fact that even as an intern and as a resident, I saved loads of money and invested early, because all of that has come to, fruits at the moment. That those are the three things, take home points: inertia, career choice, and having a backup plan, and just getting started early as quickly as possible. That'll be the three things that I'd say to everyone.
yeah, I think just
Common
getting
themes.
started is so important. I know for myself, even in medical school, I was very excited to try and buy my first property, but obviously couldn't, didn't have a full-time job, but I spent a lot of time kind of researching, getting educated, podcasts, books, seminars, courses, so that I could pull the trigger, once I was an intern. And your other point about opportunity costs, that is a real one, especially nowadays, in training, there's a lot of bottlenecks, firstly, getting onto a training program. But I've also anecdotally talking to some physicians, for example, even in a metropolitan city, once finished training and trying to navigate, build up private practice, or getting hospital staff specialist appointments, anecdotally can be quite difficult. So, kind of planning ahead is very important.
Yeah, and don't burn bridges, right? I mean, if you ever want to go back into the hospital system, you don't want to be burning bridges. That's where the 3A's come in. So, if you're a registrar about to be a consultant, never burn your bridge. Sometimes it's okay to sacrifice a little bit now for the rewards later on. But you got to be strategic about it. And of course, look after your health, look after your wealth, look after your education. I mean, at the end of the day, the biggest asset is you, right? So if you're not healthy, if you cannot work, if you cannot earn an income, initially in medicine, you have to trade time for income. That's the only real way to make money as an intern or resident. Stay healthy, stay safe, and be strategic about it. It's unfortunately probably not as easy as what it was, 30 years ago. But having said that, 30 years ago, people had challenges as well. It's not as if it was entirely stress-free back then as well. So, those are the three things. And again, here's a couple of tips, practical tips. Don't buy a new car if you're not worth $1 million. Don't do it. This is a waste of money. And don't buy too much house. It's a very common mistake a lot of doctors do. It's okay to buy a crappy house in a normal street. It's okay to maybe start with an unrenovated property. You don't need to get the best of everything as a junior doctor, as a registrar, because there's a very common thing that people run into financial trouble early in their life, and you don't want to be working to pay off your bills. When you pay off your mortgage, when you don't have any debt, the air and the water in your house just taste and smell better. So, yeah, I mean, I see this all the time. Buying brand new cars, trying to build the biggest house you possibly can as a junior doctor without a security of a fellowship. It's a bit risky.
Yeah. Thank you so much, Dev Raga, for coming on to Passive Income Doctor podcast. How can people kind of find out more about you and your podcast?
Yeah, just Google Dev Raga, personal finance. You can download my podcast in all of the major platforms, and of course, leave a positive review and a 5-star rating. I'm hungry for 5-star ratings, as you know, helps the algorithm. Or you can find me on Twitter. I refuse to call it X, and also find me on Facebook as well. So you can just contact me, a private message, etc. I'll try and get back to everyone. I try to do that as much as I possibly can. Sometimes I can't. Just get the volume of messages is a bit too much. So bear with me. The reply might be a bit delayed, but those are the ways to get hold of me.
Yeah. And thank you to our listeners for tuning in to another episode of Passive Income Doctor. Please subscribe, share this episode to your friends and colleagues, spread the word. And I think together as doctors, we can, help each other kind of become more financially literate. Thanks for listening to today's show. Please take a moment now to hit the subscribe button and share the podcast, because this will help others benefit also. So until next time, keep taking steps to improve your finance.